we'll move on to the next talk. So the next talk is going to be by Dr. Osman Ahmed. So Dr. Osman, he's a consultant at the Department of Hematology at King Faisal Specialist Hospital and Research Center in Riyadh. He's leading our strategic planning and program development for our department. He's the director of our CAR-T program. Dr. Osman will give us a talk on simple strategies, significant impact for better outcomes in hematologic malignancies.
Thank you very much. Bismillah, thank you, Dr. Hanan. Thank you, everybody, for coming. Thank you to the organizers, especially Riyadh, Abdul Wahab, Marwan, and everybody else. So this is going to be a 4 p.m. talk. So inshallah, there won't be many numbers and there won't be many curves, but I hope I can share some food for thought. Better outcomes in hematological malignancies, simple strategies and significant outcome, significant impact. Sounds really easy. Okay, but let's just take a 20,000-foot view for cancer and the cancer landscape. So we know the incidence of cancer is going to be increasing over the coming decades, and the important and sort of sobering thought is this, that most of the increase in cancer and most of the increase in cancer mortality is going to be happening in our regions, whether you're talking about the Eastern Mediterranean region, the Middle East, Southeast Asia. So all the innovations that we hear about come from North America and Europe, but most of the deaths happen somewhere else. So there's a big barrier in terms of access, in terms of interventions to improve outcomes. So, as I mentioned, low and lower middle income countries have the largest increase, or expected to have the largest increase in age standardized mortality. So when we talk about how to improve outcomes, so often at a national level, these are some of the domains that are addressed. So, having a national framework for cancer priorities, collecting data on cancer cases within a population and characterizing those, evidence-based protocols to optimize patient care and guidelines, and metrics to assess outcomes and how you can improve that. So, for example, here is the US National Cancer Plan, and it roughly follows the same theme. Preventative strategies, early detection, improving treatment efficacy, and optimizing care, and how to organize those services, how to get to that. You need data, good quality data, and to be able to leverage that data to have policies and to measure what your outcomes are and to improve them. You can't get to your destination if you don't know where you are. Removing disparities, efficient employee engagement, and getting everybody involved. So if I go, right. So now, when we talk about that, so one of the components, obviously, in terms of improving outcomes is how care is organized within a region, within a country. So having centers of excellence is important, and for centers to develop expertise is important, and that contributes to better outcomes. So this was a study from Memorial Sloan. So your survival depends on where you're treated. That's also reflected in, say, the pediatric ALL outcomes. That also demonstrated that children that were treated in more specialized academic pediatric centers did better. So, for example, here, if patients were treated in a specialized care center, they did 11 points better, or 9 points better, from 53 to 44%, so 9 points better than if they were treated in a community hospital. So that has implications in terms of how cancer services are organized within a country, within a region, or even within a city. So, for example, London, 30 years ago, had like 15 cancer centers. That was then consolidated to fewer and fewer centers that now cater for the north, south, east, and west of London. There are economies of scale. It becomes more efficient. You concentrate expertise and your resources, and you improve outcomes. So you have economies of scale. So now, at an institute of fair, you have a center of excellence, and that is a center of excellence, we hope, inshallah. So a patient comes with a suspected diagnosis of cancer to a glass and steel building like that. That's the entrance of the King Abdullah Center for Oncology and Liver Diseases, King Faisal. So what are their expectations? So, here on the left is increasingly what our institutions want of us, right? So they want KPIs, your evaluation, they want indicators, you want to discharge more, you justify everything you're doing, you want more efficient, teach more, publish more, age index, be well at the same time, discharge quickly, etc., 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 right? We've been there, we know that. What the patient wants is something different. The patient doesn't care how many publications you have, what your age index is, how efficient you are, etc. The patient comes with cancer, their life has turned upside down, they don't know what to expect, they don't know about their livelihood, they don't know what's going to happen to their children, there's fear, there's uncertainty. All they want is to go back to what they were like, right? So, what organizations want, they want performance, savings, they need operational excellence, they need a bit of fame. I think that's okay, organizations always want that. Physicians want certain things. We want some time for our family. We want incentives. Patients, what do they want? They want to be treated compassionately, and maybe in ways that we don't think about, which is why it's in that part of the circle. They want more time with you. They want all of your time, okay? We don't necessarily want that or can offer that humanly. They want to go back to how they were. They are concerned about their family, about their livelihood. But there is an overlap where I think we all want what's best for the patient. We want to provide the best care and for them to have the best outcome. Now, just this week, like yesterday, I was in the ward round and I was asking the fellow, I said, the two fellows, why are you here? We were doing a ward round, like, why are you here? What do you aim to achieve today? To which, not surprisingly, they didn't have an answer, right? You can't blame them because maybe we haven't conveyed a single aim or objective or a mission or a vision for a hematologist in training. Simply because often, as you can see over here, the priorities are very conflicting. Sometimes, even as physicians or consultants, we might be confused as, hang on, what is expected of us? What do we need to do? So in that light, I think an important aim that we should all have is a singular aim to improve the patient's outcome. And let's look at some of the ways that we might do that. So nationwide, as we mentioned, there's about awareness. We have challenges with late diagnosis, late referrals, misinformation about the prognosis or treatments for cancer. And then we have challenges of access, whether there's delays in access. Those are nationwide problems that might be beyond our scope. Institution-wide, we have challenges in terms of whether it's diagnostic services, support services, bed situations, getting biopsies or surgical delays or PETs, etc. Some of those aren't in our control. But what is in our control, our sphere of influences, our hematology programs or our cancer programs, where we maybe need to take a step back and say, all right, what is the most important thing that we want to achieve? Where are we now? What interventions should we do, and how can we remeasure the impact of our interventions? So are we following the best evidence? Do we need to change that? And do we need to update our practices? We're all resistant to change, right? I think we know that between our, Mansoor will tell me, I'm quite resistant to change, and he has to spend a lot of time convincing us. We eventually get convinced, right? So measure, and then we have to be able to measure our outcomes. And I think that should be one of the earlier priorities, even in cancer centers that are just established, programs that are just established. Very early on, we have to establish good data practices and data tools, measure these, and see how we can make those better. Because as I forget his name now, the father of quality, as he said, what you can't measure, you can't manage, right? So I think the first and most important thing for cancer centers, for hematology programs, is to place outcomes at the center of decision making. Whatever we do, whatever intervention we do, what is what we're doing, what leads to the best outcome? Whether that's a clinically reported outcome, a clinical outcome, or whether it's a patient-related outcome. So the problems, for example. So the clinical practice, the what. Are we really delivering therapy that offers the best outcomes? So for example, so the NCCN tries to make this easier if you look at NCCN evidence blocks, for example, and I try to tell fellows to have a look at this. It's a very rough guide. There's not much difference between different protocols, but it gives you some kind of guide in terms of what is more efficacious, what is safer, what is the quality of evidence, consistency of evidence, and affordability. And the more blue boxes you have, the more in favor of that treatment the evidence is, okay? And those are those boxes. So because it adds a bit of objectivity, because a lot of times our decisions or what we do might be subjective, sometimes biased. So I'm going to give a bit of a backstory to Ahmed's presentation on ALL and the curves that he showed. So that is, I think we talked about recently, if there's a fellow, that's Sidney Farber, right? Who was in Boston many decades ago, and he was actually a histopathologist, and all he saw in his damp room in the basement was samples of spleens and bone marrows that were leukemic, and he didn't understand why, but he was probably the father of chemotherapy. And they started obviously first with folate and antifolates, and then the rest is history, and that's what happened in terms of the improvement of survival for childhood ALL. That's what's been happening. Now, so I think it's helpful to share our successes, but it's also helpful to share where we learned from, where we may have not been doing as best as we could have been doing. Okay, so for example, these were outcomes on one of our protocols, the 1423 protocol, that was instituted in 1423 Hijri, right? That was the 5-year survival, just over 45%, which was not great, but actually that was similar to most centers that were adult centers treating ALL. And then we knew that we had to institute a pediatric protocol. And maybe sometimes it takes time to reach consensus and to adapt and to adopt something. And so with Dr. Ahmed Hanbali led the treatment of this new protocol, but it was difficult making a decision. Now, I wanted the UCAL protocol. The colleagues from Canada wanted the DFCI. Somebody else said, let's do hyper-CVAD. Somebody else said, let's modify the 1423. So we had lots of discussions. So then in the end, we had to say, let's ignore all of that. Let's blind ourselves to all protocols. Let's look at what gives the best outcome in anything that we have, and then unblind and then say, just choose the one on top in the Excel sheet after you rank it. And it turned out to be our pediatric colleagues. We asked them to reanalyze their data and say, look, can you reanalyze your data we want to look at it. And then it turned out they had a 90% in their high-risk patients over 10 years of age. So I said, look, we're going to do that. It works in Riyadh, it works in Saudi, it works in King Faisal, pharmacy knows about it, seems to have a better outcome than anything else. So why don't we do that? So we did that, and alhamdulillah. I think great credit to Amr, who pretty much single-handedly looks after these patients. It's very protocolized. Everybody gets treated the same way. There's protocol compliance. The patients are treated in a timely way. You don't have treatment gaps. And all of those are the green ticks that made pediatric protocols successful, right? And I think that's 75% compared to the 40%. And I think with the new interventions of blinatumomab, it looks like it's heading to even better. So I think that's a success story, but born out of a lesson learned that we have to look at our data and see how we can make it better. So here is a story that isn't much of a success story, which is our AML outcomes, which in a median age of 35, okay, fine, this is lots of patients over many decades. Since, this is the last 2 decades. So median survival of 40 months and a 5-year survival of 48% in this age group was not great. So something has to be done. So one of the factors that we've always been thinking about is how are our patients different? And this is what led to the whole genome sequencing study that was a subject of Dr. Manal Faham's PhD that she's now completed, and she got her PhD in collaboration with King's. And essentially, that demonstrated that, number one, are our patients the same? Are we treating them with precision, or are we just treating them? Are we treating the 25-year-old in the same way that a 65-year-old from Texas is being treated? Yes. Is that the right thing to do? No. So we needed precision. So at least now we have a better understanding of the genomics of our patients. I won't go into it now, but there's a graph over there that shows how this compares with the Beat AML and the University of Wisconsin database. And you can see the frequency of mutations over there is different. Okay, I won't go into details, but hopefully that will come out in publication, inshallah, sometime soon. Okay, so the what. Are we delivering the best treatment? But it's not just the what. The how is important as well. How are we delivering it? Somebody could be treating somebody with a CCG protocol in one place. Somebody could be doing it in another place. But in one place, you have a dedicated leukemia coordinator, and we have, for example, Dima Al-Marzouk over here, our dedicated, excellent leukemia coordinator. We have Maher Hassan. So a dedicated leukemia coordinator, you know, where a patient is able, they're their key worker, they're able to follow up with them. Is there clear signposting? Is there clear education? Is there clear guidance? Do we have a social worker? Do we have a psychologist? So it's not just the clinical related outcomes, it's also patient related outcomes. Are we looking at their quality of life? And this is where we need to do more work, and we need to convince our leadership that these are the things that are more important than the numbers. And then, so talking about the process. So it's not just what we do, but it's the process and performance. So the performance of our programs depends on the structure, the process, and the outcome. So that's what we need to work on, not just what we deliver, but how we deliver it, and that comes into quality. The important thing then we said is, if we don't know where we are, then we don't know where we're heading. We don't know the impact of our intervention. So we need good quality data now, and that's challenging because often data managers and retrospective databases are not seen as glamorous. What's seen as more glamorous is enrollment of 2 or 3 patients in a 500-patient randomized clinical trial. Where you question, well, how much value is that giving to our, we might get something financially, but how much value is that giving to us in terms of improving outcomes of all of our patients with leukemia, for example? So data managers, databases are really important, and increasingly we need to be able to leverage AI and higher, more intricate informatics in how we capture data and how we analyze it. Ideally, it should be built into the electronic health records. And we should have dashboards. So for example, this is a dashboard from the UK that tells you about the timelines for referral to treatment, emergency presentation, how long it's taken, and what is the 1-year survival, and what is the mortality for each of the different cancer clusters. Any hospital, you should be able to look at the outcomes and how they're performing. We need this within our institutions, and we need this across the country. So somebody can look at all the hospitals in London, for example, and see which one gives most satisfaction. And I think the one on the right is, I think, the Royal Marsden, but Dr. McCaddy is there. He can see which one is the one right on the right. The last one on the right is Lewisham. It's very surprising. It's not doesn't it have, there you go. That's why data is important. Because if you were to ask somebody about Lewisham Hospital, they say, don't ever go there. But actually, the numbers are important. So outcomes dashboard. Now, leveraging AI. So we looked at, for example, we knew that the data that you have, you can't humanly analyze it in the way that we conventionally do. And this is where we need to leverage AI. So one of the things that we knew we had big data sets for was for our bone marrow transplant database, because we have many decades of data, and we have one of the most outstanding data managers over here. We have Mr. Riyad Yunus. We wouldn't rely on anyone else's data after seeing the quality of his. So we knew we had good quality data. So the AI team in our hospital built an AI platform that fed this data into the algorithm so that we could then risk stratify the patients. So now you can predict which patients are at the lowest, intermediate, and the highest risk of complications. And that's all adverse outcomes. 100-day mortality, acute GVHD, ER attendance after discharge, ICU admissions, severe sepsis. Interestingly, and it's the ones that looks like it's the ones who have benign. So they've done the retrospective data gathering, and now that needs to be validated prospectively, and we need a champion to take that on. Maybe Dr. Hanan can take that on, all right? Okay. So this is, this was them.
1 minute left.
Okay. So this is how they looked at the variables that were taken into it, and looking at the predictability of these various parameters and this is what was used for the algorithm. So diagnostics and research, so we talked about precision. So yes, we have great protocols, but are those protocols appropriate for our patients? And again, we need diagnostics, real-time diagnostics, not delayed diagnostics, integrated reports, so that we can correctly treat our patients with precision. And then we need clinical trials, discovery, on the one hand, but you need to improve, and part of that improvement is, the aim of having CAR T-cell treatments is not to treat 100 patients a year, or 150 patients a year, or 200 patients a year with CAR T-cell. If we're able to get something better than CAR T-cell that is more efficacious, gives you a better outcome, is less toxic, then we should close down the CAR T program, right? So the important thing is not the modality, and that is a challenge. The healthcare systems, perhaps ourselves, we get obsessed with the modality of treatment. And we had the CML story. We stopped doing transplants because we had something better. And we have to work on access in a timely way so that patients are not deprived of the medical innovations that are there. So so we did a proposal for a comprehensive hematology institute, and we said the center of that should be improved survival, improved patient-related outcomes, quality of life, experience, and satisfaction. So everything that we do should, in the end, whether if we're doing phase 2 clinical trials, if something does not lead to improved survival, then we should question if we should be doing that. So if we're going to do education, it's for early detection and referral, personalized, data-driven, cancer-specific pathways, improve survival. Phase 2-3 clinical trials, early access data therapy, improve survival. MRD incorporation to detect and prevent relapse so you can intervene and improve survival. So improved survival should be the center of everything that we do. Here are a few other projects that we had proposed. It's very important to know where we are falling short. So if we have a 40% survival, I know Dr. Ahmed is here and is looking at why, for example, why in the last few decades our survival in AML is not what it should have been. So those were a few thoughts. So messages, I think, in our programs, we have to put outcomes, clinical outcomes and patient-related outcomes at the center of what we do and at the center of our policies and our strategies, and this is what we should convey to our management. With that, I think I will end. Thank you very much.